you. So, Dr. Yamaguchi is not here. In case you're wondering, I'm not going to talk about IOLs, but we wanted to fill the session, and I want to talk about keratoconus. I don't have any relevant financial disclosures. So when you talk about keratoconus, it's characterized by axial, central, or paracentral corneal thinning and progressive irregular astigmatism. Estimated prevalence can vary depending on where you are, where you practice. It usually presents in the second decade of life, but we've now started to see more patients even at an earlier age, possibly due to better diagnostic modalities. It can present variably. You can have patients who will come to you with changing refractive error, changing prescription on glasses, myopic astigmatism. You see the case of facial rings, corneal scarring, and sometimes the acute corneal hydrops as well. So we're going to talk about the hydrops here. The pathophysiology of hydrops is pretty clear. There's a break in the decimates. Aqueous seeps into the stroma, causing acute corneal edema. Patients present with sudden decrease in vision, onset of pain, and usually a lot of photophobia. Non-surgical managements, basically they aim at decreasing the stromal edema. You can use hypertonic saline as eye drops or ointment. Some physicians would like to lower the pressure as well, using either topical medications or oral acetazolamide as well. It is important to control the pain, which usually responds well to cycloplegia and some lubrication as well, because the surface becomes there's microcystic edema and early bullous changes, which are of course temporary. The goal is to prevent corneal neovascularization, because if this patient needs a corneal transplantation in future and they develop corneal neovascularization, the prognosis is going to change. So there is a possible role of topical steroids. We usually don't use them, but that's the importance of following up the patient on a regular basis. This is a 22-year-old male who has bilateral keratoconus. Right eye cross-linking was done, left eye was waiting for cross-linking and still thinking about it. He presented 4 months later with acute hydrops in the other eye. You can see the interior segment OCT shows fluid-filled pockets and an increase in corneal thickness. There is a break in the decimates membrane, and of course then there's sudden drop of vision. We talked to the patient, started some cycloplegia, tried to dilate the pupil, making sure he was comfortable, and we asked him to come back for follow-up. In 2 weeks, you can see there's further drop of vision. Look at the clinical picture and look at the ASOCT. Now the fluid pockets, they're sort of merging together. We give an option for intracameral injection of air, just to sort of, expedite the resolution and provide him some comfort. Patient refused and said, I'll think about it. The patient comes back at 4 weeks, and you can see that actually the hydrops is even worse. There is now a huge pocket, almost a cornea within a cornea. Of course, the second cornea is only fluid and nothing else. So this is 4 weeks. The vision is pretty low. Our view is quite bad as well. So we're thinking about what to do. And of course, the patient said, well, I'll come back again. At 8 weeks, the patient suddenly presents with resolution of corneal edema. So this case history just highlights the natural course of the disease over a period of 8 to 9 weeks. So even if you don't do anything other than talking to the patient, basically the edema is going to resolve itself in most of the patients. If you go ahead and do surgical intervention, you might, especially intracameral gas or air, not that it doesn't work, you might end up inducing pupillary block glaucoma or even cataract in such a young patient. Surgical management, as I mentioned, most commonly is intracameral air or gas injection. It shortens the duration of corneal edema. You're basically tamponading that break, which enhances or expedites the resolution of edema. You can use AMT, amniotic membrane transplantation with cauterization. I'll show you a couple of pictures. And of course, rarely you can perform a keratoplasty for a large decimus membrane tear or intrastromal cyst, although we don't do it anymore. A bit about intracorneal air or gas injection. It shortens the period of persistence of corneal edema. You can use air, 20% SF6 or 14% C3F8. Air works as well as anything else and actually is preferred over isoexpansile gases. You have to preoperatively constrict the pupil, make sure some fluid is taken out of the AC before you inject anything else into the AC. We usually fill the AC with 2/3 of the volume. Post-operatively, it's better to have supine positioning, topical antibiotics, hypertonic saline, and now you can give steroids because you basically entered the eye, and you can lower the pressure as well because there's always a risk of complications, which definitely include elevation of IOP. You can have some endothelial damage, although you wouldn't worry too much about that because there's a break in the decimates. You can induce cataract, which can be worrisome. And of course, your gas can migrate into a place where you don't want it to go. This is a study we did ages ago, 2011, just showing the evolution and resolution of hydrops using UBM. At that point, the anterior segment OCT was not as developed as it is now. This is a picture of a patient who had intracriminal gas injection. You can see the edema resolves quite quickly, especially in the first 7 to 10 days, actually. You can take out some fluid, doing intrastromal fluid drainage with air tamponade using anterior segment OCT. We published this series about 10 years ago now. And again, at that point, we did not have access to intraop OCT. You can actually repeat this. You can actually do this better if you have access to intraop OCT, where you can actually see where the fluid pocket is and then make sort of an incision there. This is a video which basically shows that you can. So you basically make a paracentesis, fill the AC with air, and then you preoperatively know where the fluid pocket is. You can drain the fluid, very carefully. As I said, this looks easier and less dangerous when you have access to intraop OCT and you can make more than one incisions. You can see you're basically helping quite a bit. That amount of fluid that egresses out is significant, so there's no doubt that the edema is going to resolve quicker. Rarely you can use AMT with cauterization. This was published back in 2006 in 10 eyes with where multifocal cauterization of cornea was done, and hydrops was resolved quickly. It's supposed to be a highly effective treatment for persistent hydrops related to keratoconus, and there's actually a good publication in late 90s from Sheffer Sengh's group where they have consistently used this for patients who have hydrops and are differently able, especially patients with Down syndrome. We published a short case series where we actually use electrocoagulation using a commercially available machines. You actually end up putting about 50 spots on the surface of the cornea, which basically induces scarring, superficial, and then that leads to resolution of edema. We don't do that often unless the patient, as I mentioned, is differently abled. So to conclude, most of the times, conservative management is good enough, as you saw in that case study. If you have to, you can use intracameral gas tamponade. The most commonly used gas is air. You can do corneal stab incisions, especially if you have access to intraop OCT, and image-guided intervention just makes the whole process actually very safe. Thank you very much for your attention.
Thank you for a nice talk. So is there any questions or comment from the audience?
Just a practical question, Vishal. They're not working. For gas, because these patients are phakic and you don't have a PI, do you leave a full fill of air, or do you then after a while take some out, and do you dilate their pupil afterwards? That's what my worry is after.
Yeah, we basically do the same thing as we do in EK nowadays. So
you fill it up completely and then remove some?
Yes, you can. You can actually do a PI as well, although, and again, I have to confess that I treat more than 90% of patients just conservatively because they resolve. Of course, sometimes the patients, they are starting to develop neovascularization 1, and sometimes they are in a lot of pain and they want quicker resolution. So you can fill the AC completely, wait for some time, and then reduce it to 2/3 and dilate the pupil. There is still a risk of pupillary block sometimes, but it's not as much. And that's why I prefer air over other gases.
Rather than gas.
Dr. Vanathi from RP Center had published a case report where there was actually a retroflexion of the iris, complete, following injection, I think, gas after keratoconus, Hydrops, and the patient had a malignant glaucoma following that because of misdirection of the entire thing went posteriorly because of the pressure. So it's better to leave some gap. It has to be burped out a little bit.
Okay, thank you very much. Any questions from the audience? All right, this brings us to the end